Welcome to our health disparities discussion. My name is Adam Kitchen, and we are all with the Doctorate in Athletic Training program here at Indiana State. And like I said, today we'll be talking about health disparities. I'm currently an athletic trainer, graduate assistant with the cross country and track and field teams at Indiana State.
My name is Nicholas Barrett. I am also a doctorate athletic training student at Indiana State University, and currently I have a full-time position with the Carolina Crown Drum and Bugle Corps. I am their head athletic trainer, and during the regular school year, I am a graduate assistant athletic trainer with track and field and cross country at Indiana State.
Okay, my name's Jamie Nickander, and I am a graduate assistant athletic trainer at Terre Haute South High School here in Terre Haute, Indiana.
My name's Dustin Anderson, and I'm a military athletic trainer at Fort Sill, Oklahoma.
And I am Bobby Laningham. I am the head athletic trainer at West Vigo High School in West Terre Haute, Indiana.
All right, excellent. I just want to thank everybody for being here today, and I'm looking forward to talking a little bit more about health disparities and what athletic trainers can do to not only recognize some of these disparities in the healthcare setting, but also work towards closing some of the gaps that we've seen in the literature. So to start off, if we can talk about what some specific health disparities that we might see in the athletic training profession and how we might prepare or deal with these issues. Nico, do you want to start?
Sure. I think one of the main things that we see with health disparity are individuals who are either lacking insurance or they don't have the proper medical insurance to be able to get the care that they need, and so they have to pay out of pocket. And we see this a lot in high schools or in underserved settings where they haven't really worked with an athletic trainer before, or they haven't really worked with a physician before. They don't really know how to go and see or what to go and see medicine or a professional for. And I think the main thing we can do is get a better education system for patients. And there's a really good thing going on right now. I'm not sure if some people have been watching television, like local television recently, but there'll be a commercial that says, like, I have shortness of breath and my chest hurts, and then another one says, I sprained my ankle. It's like, which one do you go to the ER for? And then it shows like a green light at the shortness of breath one. You know, so it's like little things like that that can help people who aren't able to get the care that they need to understand and be educated on how to go and when to go, so that way they can be saving money in ways, because most of them won't go for like minor things, which is okay, but they also won't go for the major things, and that can lead to a lot of problems later on. So I think mainly with insurance and getting those people the care that they need, it's one of the bigger deals. So what do you guys think about that? I was going to talk about Affordable Care Act, but I know I don't know a ton about it.
Yeah, I completely agree with the affordable part of it, especially working in the secondary school setting and in a kind of a lower income area. I see that our athletes and I also see that even people at the school that aren't necessarily athletes try to come down to the athletic training room to seek advice. Even if it's not for me to give treatment to them, it's to see if they need to seek further care from other places. So they try to use me as a kind of a informative person, I guess, to see what they need to see if they need to seek further care. I also see it more in the younger kids, where our high school kids may have a middle schooler brother or sister, and now they understand that, oh, there's an athletic trainer there, I can go see them rather than having to go to the doctor and maybe miss school or having to pay out of pocket or whatever, since we don't really have good insurance or something like that. So it's kind of trickling down to the younger kids more so than it had in the past, I think.
Working with the military setting, I really don't see any of the insurance type issues because they all have the same type of insurance with the government. One thing that I do get to see that most athletic trainers don't is just a wide array of individuals from across the country. And one of the things that I noticed early on was health literacy. So being able to explain different words and what they mean in a comfortable fashion and making them feel comfortable. For example, about every day I got to ask people if their pain is constant or intermittent. Then they're like, well, what's intermittent? And I'm like, from time to time. Or I give them a profile, which means basically what they can and can't do. And I go, as tolerated. And they're like, well, what's tolerated mean? So I think athletic trainers have that bridge of being there and sort of just breaking down the language to people that may not know what it means in a very comfortable and welcoming way, because I think we've all had either that one friend or that one teacher in college, like we may mess up something or mispronounce something, then you feel really bad from their reaction from it. So from my standpoint, I think health literacy and making them feel comfortable with the medical care that they're getting is something that athletic trainers can do.
I kind of feel you there with the health literacy type thing, especially now that I'm in an emerging setting and I'm trying to explain things to people, and I have to really, like, I used to think I knew how to talk to a patient in layman's terms, but then you think, oh yeah, like a college athlete, they've probably been around medical setting, athletic trainer, someone, and so they understand things that you say, and then it's like even just simple terms or words, like based on the education level of the person, you have to change the way that you speak, and like sometimes those people can't get the care that they need because they don't know where to go or how to do it because everything is too complicated for them, and that's happened here for me. I'll explain something like, oh, did you do this? Have you done that? And they're like, what do you mean? I don't know what the words you're talking about. You know? And so I'm like, oh wow, so I had changed the way I explain things. But yeah, it's common enough where it doesn't seem like it should be, but literacy and understanding concepts is probably one of the bigger pieces of why these individuals aren't getting the care that they need. Because if we think about like minorities and women in general, or those who are oppressed in society, they aren't going to go out of their way to be oppressed. You know, like they aren't going to try to, and if those areas aren't available to them, then they aren't going to put themselves out in a place where they can feel embarrassed or they can feel like they don't belong in an area because they don't understand what's happening. It's kind of like if you go to another country, you really don't want to mess up the language and speak it wrong, because then everybody's going to look at you and look down at you, maybe not treat you the same as everyone else.
I want to talk about health literacy just a little bit more, and I want to get Jamie's perspective on what her experience is with health literacy and whether or not you feel, Jamie, that you're having an impact on someone's health literacy when you're either explaining the process of what you're doing to someone, or if trying to educate them on the healthcare process and not just their own injury, but what goes on and how they can probably help themselves with future injuries, that sort of thing.
Yeah, I think, you know, kind of Bobby touched on this. At the high school setting, you get such a wide array of experience and health literacy and just health in general. You know, when I talk to someone who's 14 versus someone who's 18, I mean, that's just a huge difference. And so I think that the education is such a big key in the high school and younger population. just because a lot of times if I say I'm going to refer you and I say I'm going to refer you to our orthopedic surgeon, you know, they have no idea what that means. And so I definitely think that just talking to them, and I actually have a lot of patients for some reason that seek chiropractic care, and I think that that comes from parents or just exposure. Like, people know what chiropractic is. So if I have back pain, that's where I'm going to go. And so I think that not only the process of, you know, what I'm going to take them through, so I'm going to look at you for this reason, but we might have to refer you for this reason. I think that that, like you said, for their specific injury is really important, but actually educating them on all their different healthcare options, especially at that age, just because they haven't been exposed to it, is really important. So for them to understand, you know, what my role is versus what a physical therapist's role is versus a chiropractic care, and kind of how all of those things should interact rather than one's better than the other, I think is a really important thing to explain to kids to hopefully for their, you know, future understand where and how they can kind of help themselves.
That makes a lot of sense. I'm glad we were able to get your perspective on that, and it seems like a common thing that health literacy and patient education is one of the main things that athletic trainers can hopefully change with our own behavior, so we can improve patient care and decrease or increase health literacy, so that people after college or after high school going through the healthcare system are better able to navigate it. So moving on towards the Affordable Care Act, I know we mentioned that a little bit before. Why do we think that health disparities are still as big as they are, even with things like the Affordable Care Act? So what other factors could be influencing these health disparities, and do you think athletic trainers can be used within these government programs to provide affordable care? Anybody? Or Nico, you might have to turn your mic on.
My mic wasn't turning on, but I was pressing it. I was like, come on. Yes, 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 yes. One of the main reasons that I went into the athletic training profession, I was originally wanting to go into biochemical engineering or biochem and cure cancer, save the world. You know, I wanted to be a physician. And then I found out how the American healthcare system worked. And if you're a physician, you see 60 patients in a day, you see them for 15 minutes, you give them a pill, and they go home. And no one's getting fixed, no one's getting cured, no one's getting the right treatment they deserve. They go in, they get their feel good, they go home, they feel bad again, they go back, they get their feel good, they go home, right? And I didn't want to be a part of that. I didn't want to be a physician who didn't help people and just basically treated people for their entire lives. And that's the problem with the American healthcare system, is hopefully it can change at some point, but athletic trainers can change that dynamic by giving patients the care that they deserve for the longer period of time. Like, if physicians spent 45 minutes with a patient, then we would have so many less surgeries that need to be done, pills that people don't need to be taking, educating the population on what they need to be doing, you know. And the other thing is that people have to change what they need to be doing. People don't want to change what they do. They just want to feel good and they want to go home. And that's why physicians make a ton of money. You know, so, well, make enough. That's why we have the system that we have, and it's not going to break unless we break it and fix it. So, like, athletic trainers can be, if we could set up our own practice, that would be awesome, but we can't. You know, but if people can go to someone and get like a 45-minute sit-down talk, check it out, here's what you need to do, you know, and not pay a lot for it, but still the person doing it isn't like drowning in debt and can provide care and have the service that they need to do, then, you know, like, that's where it needs to go. And some people say, like, that's what physical therapy is, but it really isn't, because they're trapped in the insurance bucket. Like, if they don't provide the right amount of care, they don't, like, treat enough people within the insurance bracket, then they don't get their money and their practice dies. You know, so I don't really have a solution for it other than we have to destroy our healthcare system and rebuild from the bottom, which everyone is like, what? You know, but we're like number 50 out of like healthy people in the world, but we're number 1 in spending for health in terms of the United States. And that's a big deal. You know, like, why are we spending so much money but people aren't getting better? And I think we need to spend more time with the patients and educating and giving that service. And if that means athletic trainers go out and they provide like a free clinic like there is in Terre Haute that Dr. Demchuk does, you know, like, that's awesome. Stuff like that. So what are your guys' thoughts? I know I just blew up the entire world, but
I agree that a lot of people don't want to do, well, I guess what is in athletic training, they don't want to do what's tough. Like, a lot of people don't want to do rehab and that sort of thing. They want their feel-good stuff like you talked about. But I think one of the important things that we gotten from the literature, some of the readings this week, was that a lot of the factors that aren't necessarily on clinicians, it's the patients not being educated enough, which we can change, but sometimes it's a societal and cultural thing. Like when we saw that in setting up programs in barbershops so that people have a community and building trust, more of a community thing, because people will go to each other in their neighborhood or their community or their church or their social group to seek out advice for practitioners, and so some of that is a sociological thing. And I thought that was really, really interesting. And maybe it's not just okay, we got to tell all the physicians and any clinician that sees anybody in any of these groups that they got to educate somebody really well and convince them of something. Well, people are trying to do that and it's not working. And so I think that's why they started implementing some of these programs and community-based things, because there are many more factors besides just, oh, when you sit down with a patient and they come into your office, you got to explain everything to them really well, and hopefully they make the right decision. Well, sometimes that doesn't work, and so there are other things we can do.
Yeah, I think you all touched on some good things. I think we do have more of a reactive healthcare system than a proactive healthcare system. And coming from southwestern Virginia, which is a pretty low socioeconomic region in that state and in the South in general, it's a very clannish type community. So they're very suspicious of outsiders, doctors, everything else. So I think athletic trainers have the ability to possibly come in and, like Nico said, in a perfect world, open up our own clinic. We don't have that stigma of doctors. Like, you're going to go to the doctor, you're just going to get a pill, and you're not going to get any better. I think another skill set athletic trainers bring to the table that most healthcare providers don't have, we're used to working with multiple people all the time. So we're used to being a gatekeeper of a sort. Like a general physician is a gatekeeper. We could be, that gatekeeper for musculoskeletal care in the community. We could run classes because at some point in time we've had to teach a class, or we've had to do these things. And I think we have a unique ability and a skill set to be very flexible, sort of like an amoeba. We can sort of just move around. We're not rigid. We're not stuck in one form. And we can definitely help those communities understand what it is to be healthy and how to get there, and not be as intimidating as a doctor would be.
Yeah, I think to kind of feed off all that, kind of taking experiences from my clinical setting, and even though I don't work in a necessarily underserved population, I think it kind of works together, even in the underserved population. I find that word of mouth is a very big thing as far as the patients that I see. Maybe, like I said earlier, maybe somebody has a brother that's a middle schooler, and even though I don't technically work with the middle school, I am willing to see that patient, and maybe I can give them some kind of information that they need for their injury or something like that. And I think that's where I get most of my drive for the professional, why I love what I do, is I can provide information and I can give out valuable information to patients. Maybe I may not be able to treat them, but I can give them the information they need to maybe later on down the road they will know what to do in that situation or something like that. So I think as far as affordable care and stuff like that, we are a very good asset to patients. They are more willing to come see us than go to the doctor, I think, for the most part. And when when patients and parents and things like that realize that we can provide just as good of care, sometimes if not better, than going to see a doctor, they would be more willing to come see an athletic trainer for their problems or for their injury or illness or whatever, than just running straight to the doctor and getting a pill or something like that.
I think this discussion is great, and I think a lot of the focus has been on how we as clinicians or providers, even physicians and stuff, how we can change, what we can do. And what I'm going to add to that is my research project is on a rural population, so an underserved population. So I've read like a lot of other literature kind of on health disparities in those types of communities. And one of the biggest things is the amount of specialists that are available for rural communities. So if you need an oncologist, you have to go 2 hours away for one, things like that, or even an orthopedic surgeon or a pediatric specialist. And so I think, you know, those types of things, even transportation to those places is a huge barrier. Like even if you have these amazing doctors and physicians who want to help these types of populations, their hospitals and their clinics are put in urban communities, affluent communities. So the outreach, I think, is a big part of that. And I've worked at a previous high school that I think was a little more like a lower socioeconomic class. And what I think, when I think back to that, would have been really beneficial, and I think athletic trainers can, especially in those types of settings in high school, I kind of see this a little more useful, is bringing specialists to them. So I think that not only do we have a really great bridge to our patients and how we interact with our patients, but I think that we create relationships with other healthcare professionals really well. And then I think that it can be part of our responsibility to educate those other healthcare professionals and try to get those healthcare professionals to come to our patients, like a dermatologist to come talk to my wrestling team so I don't have 12 kids out for skin issues, you know? And so I think that that's another one of our responsibilities. So here we are with relationships with patients, but I also think our role also comes with other healthcare professionals as well.
So to piggyback on that a little bit, just a cool story. The doctors I worked with in grad school, the orthopedic surgeons, when they graduated UVA, they sort of looked around the country and sort of like, hey, this is where we might want to go, and found the place where they worked at in West Virginia as sort of a underdeveloped area for orthopedic surgeons, and sort of seen like, hey, they have to go this far just to get this amount of surgery, and they sort of took it upon themselves to go there to start their practice, which I thought was pretty cool. And they sort of become leaders in total knee replacements and things in the state of West Virginia. So it was pretty cool to hear their story and work with them.
I think kind of linking some of this back to the literature and some of the readings that that were posted, access to care and patient-centered care were two of the big health disparities that I talked about in the readings. And as athletic trainers, we strive to be available to our patients. As far as access to care, we want to be there. We're there all the time, and even times we're not supposed to be there, we're there, which sometimes can be a bad thing, but that's something that we really strive to do. We want to be available to our athletes, provide them the care that they need to become better athletes, to heal from injuries, psychosocial issues, things like that. And also patient-centered care, we want to see our patients succeed. We want to see them back on the field. So we want to provide our care around them, so that, because they are the ones that we're there for, so we want them to succeed and to heal and to become better than what they were before their injury. So those two, at least those two health disparities are big within the athletic training profession.
I also think I'll touch back on kind of what Bobby and Jamie were saying before. It's like, it's not really that the people aren't there. It's that we need to get the people who need help to the people who can help. You know, and the other concept is the environment that that individual is going to be treated in going to be positive for them. So you take a rural individual going into a high-level class society doctor's office, they are going to be completely lost. And they're not going to know where they need to go, what they need to do, and the simple concept of going in and signing in and sitting down and waiting, they won't know what to do, and people are going to look at them like they're stupid, like, hey, you need to come over here and sign this sheet. You know, like sassy secretary ladies. Happens all the time. And I had that happen just recently with a patient. I went and he was from overseas. We went to a CVS, and he couldn't really, like, he's German, trying to read English, and I was letting him do it on his own because I wasn't going to, baby him. He was reading it, and he was like doing it pretty slow. The lady behind us was like, "Excuse me, but you're taking very long to read that." And he goes and looks at her and he's like, "Excuse me?" And she was like, "Oh my gosh, like, like, he's from Germany," and she liked his accent or whatever. But it was funny because, like, she was bagging on him for taking time, and, like, what if someone literally couldn't read it or they couldn't see it? I also, it was a different time. There was a guy who was trying to order something and he couldn't read what it was. And the people behind him in line were getting really mad, but, like, he couldn't see, but he was buying vision stuff. Like, it was funny. But then we also have to think about individuals outside of socioeconomic status or racial status, but also LGBTQ status. So if they're in an environment that is negative to them, and I've seen this in the athletic environment a lot, if there's negative skews and language that's being used in the office environment, athletic training room setting by the patients or by the clinician, then those individuals are not going to feel safe in that environment to come and get treatment. They're going to feel like they're going to be attacked. They're going to feel like, and they're also not going to be vocal to talking about those issues with the physician or clinician or whoever, while other individuals are in the room, based on that negative environment. So I feel like physicians' offices should be, or clinicians' offices, athletic training rooms should be a safe place for those things to happen. And if that doesn't crack down in multiple areas, then those patients who are receiving that oppression won't feel safe to get care that they need in those environments. So that's a definite change that needs to happen all over the place.
Just to piggyback on that a little bit, working with the military, we have to go through mandatory training, like EO training, which is equal opportunity training, and SHARP training, which is sexual harassment training. And that was one of the things I was like, okay, what's EO? Then they explained it to me, and I've sat through 3 or 4 like equal opportunity classes. And say if someone comes and sees me and they feel like they did not receive the level of care that they needed for gender, race, sexual orientation, or anything else like that, they have the ability and they have the right to go file a complaint, and there'll be an investigation. And I think if I ever go back to the athletic training community, or like the collegiate community as a head athletic trainer or something like that, I think it would be beneficial just to have those classes and have that type of training at least quarterly or every 6 months for the staff, just to avoid those issues that you were talking about. When you walk into the athletic training room, it should be a safe environment, and you should know that you're not going to be discriminated against, and you're going to be treated as a human, as you should. And if your staff can't get on board with that, then they need to go work somewhere else.
I think that's a good point. It kind of rolls into another question that I want everyone to talk about a little bit, is that obviously we have to be aware of our own biases when we're dealing with patients, either minorities or LGBTQ and everything. So obviously being aware of our biases and then trying to correct those is important, but what are some things that you think you can do to foster a better environment in your workplace if something does happen? Just ways to improve the environment so that people feel safer and hopefully are comfortable where they are.
I think that I see, not intentional sexual harassment, but like I work with high schoolers. High school boys are just, and Bobby, I know Bobby can attest to this, they say the most obscene things at the most obscene times. And, you know, even though most of them I don't think have malicious intentions, you know, I obviously have a lot of females. And again, like I said, I can have an 18-year-old boy in the same room as a 14-year-old female, and their, you know, emotional maturity, general maturity are going to be really different. So as much as the guy thinks, hey, his friends think it's funny, this particular girl might not. And so I think that I have tried the best I can to say something. And I can actually think of one particular athlete this year that I've had to say, hey, that's not appropriate for the athletic training room. Like, hey, we're not going to talk about that in the athletic training room. Like, take that back to the locker room type of thing. And I think that, you know, at first I tried to say it very personal to him, quiet, and it wasn't helping. And so I think what I decided to do was tell him that I was uncomfortable with that language, because I'm hoping to almost be a role model for those girls, that, you know, I'm saying it out loud, I'm saying it so other people can hear it, so that hopefully if that happens to her and I'm not around or someone else is not around, that she has the confidence to say, hey, that makes me uncomfortable, we're not going to talk like that. And so, like I said, I think it happens all the time, not even just between females and males in the high school, but males and males in the high school setting as well. And so I think just being vocal and specific about what is appropriate and what's not in your athletic training room. I mean, even if you have to post rules on a board, what is and is not appropriate, then I think that's going to help foster the athletic training room, but also people's future as far as that type of abuse goes.
And I think I do the same thing. I mean, if we're in the athletic training room and somebody's making a derogatory remark or something, it's not the place for that, and we're not going to have that in the athletic training room. And I also have found myself, which I think is a good habit, even if I'm in the hallway or if I'm out at the baseball field or football field or wherever, and I hear somebody make a comment, whether it's just a cuss word or maybe they're commenting about somebody or whatever, I always try to make a remark to them, hey, cut it out, we don't need that. So that way they know, like, it's not only just athletic training room, but it's life in general. Like, that stuff isn't acceptable. That's not things that you should be saying. You shouldn't be talking like that. And I have found, even from them to me, sometimes I'll slip and say a cuss word every now and then, and they jump on me, hey, you shouldn't be saying that. It's like, thank you, I know that. So it kind of goes both ways on that, and I feel like I'm making a good stance on that, and I'm making a good impression on the athletes and the students. That way they know what's right and what's wrong, and I shouldn't be talking about this, and I shouldn't be saying stuff like this around other people or in general.
Yeah, I think you make a good point, Bobby, of, you know, you got to just have the courage to act. And I think a lot of people want to, I think the majority of people want to say something, but they just don't, because they don't want to have that potential conflict, that potential, you know, difficult conversation. But at least for mine, that's how I was when I first started working in this setting. But I found out it's got easier as it goes along, because you sort of failed and you've sort of been in that conflict, and you sort of know how to talk to people about that now. And no, I just think that was good that you know, that you do that, and I think we all try to do the same thing.
I think that relates really well to, like, the general concept of educating people, and like the 6-month thing that you were talking about, Dustin. Like, every 6 months, every year, there should be an education system for the clinician or the medical provider that emphasizes creating a safe space. And then if that happens, then it's put in their minds consistently to continue to tell the patients to create a safe space for other patients and for other clinicians that are working with that medical provider, athletic trainer, physician. Good thing is there are good systems for that, but what about the settings where, like the one I'm in right now, it's just me, it's not really other medical providers, and then I'm working with 18 to 21-year-olds. and they, sorry, yeah, 16 to 21-year-olds, and they're with each other all day, all the time, and then I have to create the safe space within their zone of what everything is. Like, I've created, like, it's not like a legit room. We're like traveling all the time, so like going from place to place. So it's not like this is the safe space. It's like where I am is the safe space. So like even when I walk past a cafeteria table, they all kind of stop. You know, like they stop saying it because I've already brought it up a couple times to some people. So the other thing we have to think about is whenever you're representing yourself anywhere, that kind of has to happen too. And that's the kind of scary thing in general with medical providers is you see a lot of people, you're going to see a lot of people, and people are going to look to you all the time. And you kind of have to have that professional aura to make sure that safe space happens whenever you're around. And like you said, Bobby, like people will catch you slip up, you know, but you just got to do your best, and then like be yourself when you can be yourself or whatever. But just thinking, I was thinking about that while we were talking about it, and the safe space moves no matter where the office is.
I think that's a really good point. I think that pretty much wraps up our short discussion about the environment and how we can impact the environment around us and make a safe space for everybody. So moving back to some more specific health disparities, in the readings we saw some interesting things about differences between men and women in the healthcare setting and what some of the disparities with their situations are. And so was anybody surprised by what they saw between in that infographic or in the longer report about men and women, and then do you think the clinician plays a role in the gender equality in your setting specifically?
As a female, I can say something's definitely surprised me. And I was almost like caught myself being a little irritated. And I don't know what the like medical decisions behind this were, but I think it was the one where it like an orthopedic surgeon was 22 times more likely to suggest a total knee replacement to a man versus a female. And I don't really understand, you know, why that would be. You know, I don't know if there's assumptions that men are more active than women at a certain age, or that they're going to heal better, or, you know, whatever it might be. I think that those types of things definitely surprised me. And so I think that in my own clinical setting, it's really important to remember, and I don't think that I do, but I think maybe as clinicians in general to remember that football, a male sport's not any more important than this female's soccer game. You know, so that her injury is just as important as his. And so I think that and their long-term health is just as important. So I think that's something to remember.
Yeah, I was surprised by the men and women comparison there. I know myself, I'm going to provide the same care to no matter who walks in or no matter who's injured, regardless of their sex, their race, whatever. Their sport. I'm going to provide the same care to them regardless. And however, I have seen in my setting as far as coaches where they may be more apt to respond to a athlete that is more one of their better athletes rather than one of their not so good athletes. So comparing a starting shortstop compared to the freshman player that doesn't hardly ever play, they're probably going to be more apt to refer their starting shortstop to me than they'll probably just tell the other guy go get some ice or something. So I have seen that a lot, but on my end, I'm going to provide the same care regardless, no matter what their situation is or no matter what their sport is, no matter any other characteristics. I'm going to provide the same care. So that's what surprised me about some of the statistics. And I think also along with the stats, there should be a description within the stats of why the stat is the way it is. So 22% of whatever the stat was that Jamie said, well, why is that? Is there certain reasons why they're doing that? Is like she said, is it because the male heals better than the female in the knee? Whatever. I don't know what it is, but they need to have some kind of description of why that is. Is it just because it's a male and a female, or is there a certain reason why they're doing that? And if it's just because it's male and female, then there's a big issue with that. So I think there needs to be some deeper look into that area. But on my end, in my clinical setting, and I think that I play a huge role in that because I'm the one providing the care. And so if I start differentiating my care between male and female, or black and white, or football and girls soccer, then there's going to be all kinds of issues with that. So I feel like I provide the same amount of care regardless of the situation.
I'm glad you brought that up, Bobby, because I wanted to put in a little bit about the female stats, and like since we're talking about some of those stats, when in the literature they were talking about the level of pain, I think it was before a knee replacement or before a surgery, females had a higher level of like dysfunction and a higher level of pain compared to men, and so they wanted to try and see what that is, and they suggested that it was probably because of the typical female role in the household, and they didn't want to seek care as early, so their pain got worse before they sought care because they had other duties with home and children and the typical female role in society, which was really interesting. And so that stuck out to me pretty prominently. And so some of those things, like when you see those statistics, you're like, okay, I can't change that. Like, these are really complicated things. So I thought that was interesting. All right. Yeah. Does anybody else have anything to add?
Oh, I was just going to wrap that up. I think that just kind of basically boils down to patient-centered care. So if you're looking at a female and she's more worried about going skiing next weekend than she is about making dinner, obviously you should, as a provider, be more interested in, getting her knee better or whatever it might be. So I think us as athletic trainers do, and we're learning in this program so much about patient-centered care, and I think all those, that whole disablement model, those types of social factors play just as much of a role, as the typical things do.
I also wanted to make a comment about like what Bobby said. It's like they give these stats about like men and women, but they don't really explain it. The one that stuck out to me was that patients and providers think of osteoporosis as a woman's disease. Like, where did that come from? Why? I don't think I've ever heard of that before. And it doesn't really, I'm trying to think of how that could work. Maybe osteoarthritis, because women have different joints, but osteoporosis is bone breakdown, and you can get that from drinking too much soda. How is it, like, women get this more, why, how?
They do because of after they have menopause, their hormones change, and so the bone breakdown actually happens a lot faster. So that's why they typically called it a woman's disease, because those hormones they're not changing as much in men when they get over the age of 50, 60 years old, and so that's why that was
right. But like, what about before that? Like, are women more likely to get it before then or not? That was kind of my thought. Like, women in general, not just over 50.
I think it might be like just a general assumption that men are bigger and they reach a greater peak bone density than women. But right. Working in the military setting, I think it's becoming a null issue because I see the same amount of like femoral neck stress fractures in guys than I do in females, and I think we're switching. I think it's becoming more of a cultural thing where they're not moving as much, the diet's not as good, and they're not playing as much. They're not getting outside, getting vitamin D, and having a good diet with anything. So I think it's where I am. I thought it was sort of more of a woman's issue too. But getting here, you sort of realize no, it's not. It's becoming not even an older individual's issue. It's becoming a youth issue because of the change in activity, diet, and sort of the American way of life.
Alrighty, well, I think that wraps up our discussion about health disparities. I think we had some really good topics, some good questions, and some good insight from not only the collegiate setting, but also the high school setting and the military setting. So I'm glad we had a variety of perspectives in this discussion. So again, I just want to thank everybody for joining in the discussion today. I learned a lot from everybody, and good luck with health disparities in your own setting, and thanks.